So, welcome all to AAHCI Southeast Asia webinar. The topics of webinar today is medical education during the COVID-19 era, adapt to the change. First of all, as the regional ambassador at Association of Academic Health Center International, Southeast Asia, and Dean of Faculty of Medicine, University of Indonesia, I'm truly delighted to welcome all of you to our special webinar today, bringing the topics of medical education during the COVID-19 era, adapt to change. Thank you. Here we have the moderator, Professor Dr. Skerbier, and also we have three panelists, Dr. Coralie from University of Philippines, Professor Ian Puran from Duke NUS, and also we have Professor Gandes from Gajah Mada, Indonesia. It has already been nearly 5 months since the World Health Organization declared a public health emergency of international concern in January 30, 2020. Today, we know it is COVID pandemic, a global catastrophe with impact millions of peoples, countries, governments, and also institutions. I'm sure all of us in each institutions are already taking measures and adapting well to this pandemic. We begin by changing teaching and learning activities from conventional face-to-face to online lecture and exams. In our faculty specifically, we made a special COVID-19 module to include our medical students into the current issues. Collaborations, in my opinion, is important in this era of global issues. Therefore, we had engaged with other faculty to collaborate, such as with Faculty of Engineering to make ventilators and many kind of personal protective equipment, and also with Faculty of Computer Science to make an integrated applications regarding COVID-19, which include an applications for coordinating PPE needs. And also we have a society assessment for potential exposures of the virus that we call incorona.id. We also currently have multiple ongoing research from the use of herbal medicine as a prevention, development of diagnosis kit and vaccine, development of vaccine, to clinical trial of stem cell and also plasma convalescent therapy. At last, we also coordinating with our alumni in channeling funds by providing PPE to some hospitals, and also coordinating with the student-based organizations with focus on providing food and PPE to medical teams in the front line. As the regional ambassador, I also proudly announced that the AAHCI Southeast Asia had done many in this past month as well, including roundtable discussions with deans and professors regarding critical issues and challenges faced during the global pandemic, and also publishing newsletter that consists of 5 unique perspectives on COVID-19 in Southeast Asia regions. Therefore, I hope this webinar can bring that success even further. Before I take too much time, I would like to introduce Professor Skerbier as the moderator for today's webinar. Professor Skerbier is a professor of quality promotions in medical education and was a dean of Faculty of Health, Medicine and Life Sciences and vice chair of Maastricht University Medical Care until this month. With more than 300 papers in international peer-reviewed journals about medical education research, he had been a consultant to medical school in various countries including Indonesia, Ghana, Nepal, and Uganda. He also enterprise as a CEO and chairman. It is an honor for us for having him as a moderator for today's webinar. Last but not least, I would like to express my highest appreciations, especially for Habiba from headquarters of AAHCI, and also for participants, deans, and other representatives who participate participated in the spatial webinar. Finally, I hope that this webinar will be an opening to bright journey and that every institutions involved here can enjoy many benefit and positive things. Thank you for your attention. Please, your time, Professor Abel, to moderate this webinar.
Thank you, Prof. Ari. And maybe you easier name me Albert as you are used to, because I have such a very difficult Dutch name. Well, we have 3 speakers from different parts of the world, because the intention is also to learn from each other, which is the basic thing why we join each other in the AAHCI. Our first speaker is Dr. Coralie Therese Di Macali. She's a nephrologist by profession, and at the moment Associate Dean for Academic Development, College of Medicine, University of Philippines. Dr. Coralie, the floor is yours. You should unmute. Yeah.
Okay, good afternoon, everyone. So thank you, Dean Ari, for the invitation to join this afternoon's panel and to share the University of the Philippines experience regarding medical education in the COVID-19 era. So we all know that education is a basic human right and a core element of sustainable development. It is the 4th SDG of the United Nations and seeks to ensure inclusive and equitable quality education and promote lifelong learning opportunities for all. Okay, so I shall share my screen. Okay, so for this afternoon, this will be my outline. The effects on education during community quarantine, the challenges that we faced, and the strategies for transitioning to flexible learning. So face-to-face classroom education came to a standstill as a result of the lockdown. For us, it was as of March 11. Medical students and our interns were pulled out of the hospital wards, and classes, including internship, were suspended for about 6 weeks. Even online classes were stopped for a while so that those who had no internet access would not be disadvantaged, and also to allow our faculty to prepare for this. So faculty had to learn how to conduct online classes, use the learning management system, use Zoom, small group discussions, and other types of software. We had to prepare alternative schedules and requirements for our transition from a full face-to-face to something that was basically fully online. So a day after our lockdown, about 25% of our interns volunteered to help. Some courses, such as community medicine, fielded their students to the Department of Health. Some were assigned to the Bayanihan na Operations Center that screened calls and queries about anything from donations to hospital admissions. These students probably learned more about inequities in health brought about by the pandemic. They were witnesses to our fragmented healthcare system and unpreparedness in dealing with the pandemic. They probably learned more about social determinants of health in that span of time, something that they would not have been able to do prior to the pandemic. But they also witnessed the Filipino bayanihan or collective community spirit that prevailed. So staff assumed a work from home status. The university decided to purchase a Zoom subscription for all the SGDs and meetings that they foresaw would occur. But this fear of uncertainty about their education and of contracting COVID-19 added to the mental health concerns of our students. So in a survey of our students, among those who answered, as high as 40% were diagnosed to have or had moderate to severe depression and anxiety. Of course, we had to talk to them and we had to call them and make sure that they were doing okay. So the Commission on Higher Education, or CHED, issued a series of guidelines, okay? And they were called COVID advisories. Basically, the guidelines authorized higher education institutions to deploy available flexible learning and other alternative modes of delivery and assessment, and allowed the HEIs to select what was best based on available resources, both for the school, for the faculty, and for the students. And the HEIs were cautioned to exercise maximum consideration and leniency, especially in submission of course requirements, especially for those who were disadvantaged. They were also advised, our institution was advised, no failing or incomplete grades could be given to our students. So early on, we recognized that internet infrastructure was insufficient for about 30% of our students. So some of them had a lack of internet access, some of them had insufficient bandwidth, some of them had spotty internet. There was also the prohibitive cost of internet access. So we are spending about 25,000 pesos, or about 500 US dollars every month, for those who need internet access in terms of data usage. There was also, some of our students had a lack of appropriate devices to access the learning management system. And so we have been able to loan a few laptops for them. And we realized that the faculty learning curve is still steep regarding online teaching and assessment. This is the number one here is an issue. Faculty have conflicting demands between service, teaching, and research. So why is that so? Our faculty are advisors to the Department of Health. Our faculty are members or heads of specialty societies that have been creating evolving clinical practice guidelines, reviewing the literature. And we have faculty who are researchers, who are lead researchers for many of the COVID researchers in the country. The second issue is also important. We have difficulty in selecting alternative learning and assessment strategies, especially when it comes to clinical work. So this is a problem for the clerkship and internship years. And because our students rotate in modules or in blocks, there were those who rotated in certain departments before the lockdown and those after. And faculty felt there was inequity in grading, and some of them wanted to just give a pass. Others felt that we still needed numerical grades. So that became an issue. Then there was possible insufficient staffing and time to produce learning material. So at the time of the COVID, it was really just not so optimal. And we're still trying to complete requirements. But in our university, the extension for submission of requirements was moved all the way to May of 2021. Okay, so let's take a look at what we can do or how we are adapting to change. We realize that we will not be able to return probably to pre-lockdown normal status, perhaps until an effective vaccine against COVID may be found. We need to embrace change and adapt to it. And we need to prepare for the new normal. So here are some strategies for transitioning to that flexible mode of learning. For our policymakers, we need to lobby for a legal and regulatory framework that encourages investment in connectivity and services, lowers the cost, and fosters creativity to enable access and realize the internet's value for education. So this would include lobbying for better infrastructure to support e-learning, increasing bandwidth, especially in schools, decreasing the cost of internet subscription. So we have some universities and colleges that have contracted telcos so that they can get discounted internet subscription rates and discounted rates for pocket Wi-Fis to improve connectivity. We would like to lobby for government subsidy of the cost of these services, especially in state colleges and universities. And there is a need for these policymakers to review and update policies to foster greater equality in access to learning resources, especially for our disadvantaged groups. And for our disadvantaged groups, that includes those with spotty or poor or no access to the internet, because we're shifting to e-learning. So here is a grid that our CHED gave us. They asked us to, for every curricular requirement, here I'm just showing the internship year, to categorize how it would look like or how we could deliver the appropriate activities, let's say for internship, for a category 1, 2, or 3 student. So a category 1 student is a student who has absolutely no internet or very, very limited internet, against a student in category 3 who has unlimited internet. So the category 2 student would be in between. We feel that there is really no substitute for experiential learning, and practicum would have to be done where it is available. So if the student goes home to the province, we need to contract maybe our doctors there and ask the students to do practicum where they are. The paper cases are a poor substitute, but we can try prepared case vignettes and manage them as patient management problems, where the student is allowed to choose a course of action and then eventually see the consequences of his course of action. So this still is an issue. One of the issues maybe we should raise is, are we going to also allow our students to rotate in the COVID wards? What about assessment? So we have had to shift to online assessment, and our students complain that they have difficulty connecting to the internet. So for summative assessments, we were thinking of time-limited summative online exams. And but if you are in a category 2 status, you might have spotty internet. And so we were thinking that maybe we should have to increase the time for these students in taking the exam in anticipation of their poor internet. For the category 1 student, they will have to be given a paper and pencil long examination, and that may need coming to school. What about medical schools? What can medical schools do? We recommend that medical schools review and redesign the medical curriculum to include outcomes that are necessary to make blended learning succeed. Or, yeah, for example, probably improving digital literary skills, focusing on telemedicine or telehealth, probably ensure more focus on infection control, population and public health, maybe even pandemic modeling, and we need to look at health equity. At the current time, we are conducting a survey among students to identify their preferences for learning. Why so? To keep in touch with their educational needs and to more efficiently utilize resources that the students are more likely to use. Okay? The school should be able to provide reliable and supported instructional technology, train their faculty, students, and staff on flexible learning. We recommend the curation of the content of open educational resources and MOOCs, and investment in IT staff availability for technical support. I get a number of complaints about our technical support. Okay, we need to create a relevant and reliable digital library of resources, ebooks, webcasts for teacher and student use. And we would like our schools to ensure that budget is available for the purchase and support of e-learning. And perhaps for those without simulators, to try to get access to simulators for training students on required clinical and procedural skills to ensure patient and student safety. So take-home messages. Medical education will need a facelift and will require more flexible modes of learning, including creative approaches to learning patient care. The challenges of internet infrastructure and access need to be addressed to ensure inclusion and realize the internet's value for quality education. And we need to remind our faculty and our schools to maximize the use of already available resources and consider their usefulness to students and faculty. So thank you very much.
Thank you, Dr. Kohali. And thank you also because you are excellent in time. That's good for our schedule, and great overview and many solutions, because we also have a kind of revolution in medical education. So thank you for the great overview. We will do questions and discussions at the end. So we go to our next speaker, Prof. Ian Curran, Vice Dean Education at Duke Nus Medical School and co-director of Academic Medicine Education Institute, a joint institute of Duke and Sing Health. Prof. Ian Curran. The floor is yours.
Thank you, Dean Ari. Thank you, Prof. Albert. Can you see my presentation screen? Okay, thank you all. So I'd like to sort of build on some of the comments that Dr. Kohali shared with you in the last presentation and give you the perspective from Singapore. Obviously, some of the challenges are very similar, and some of the challenges and solutions are somewhat different. So looking forward to sharing our learning and learn from you also. So I'm just going to briefly go through 4 or 5 sort of main points which we've encountered over the last 4 or 5 months. Singapore was in the vanguard, if you will. We had our first case in mid to late January. We had clinical suspension of training from the 7th of February. So we've been enduring the COVID response for some time. Just to orientate you briefly to our curriculum, we're a 4-year graduate entry style US program, a partnership between Duke University and the National University of Singapore. But broadly, we have a condensed preclinical, which is basically 1 year, where they do learn basic history taking, examination skills. So obviously that was a challenge. They then go into clinical clerkships for a year in their second year. The uniqueness of the Duke curriculum is there's an extended research and scholarship phase of between 6 and 9 months. And that's particularly to concentrate on a research and scholarship project. And in some ways that's been to our advantage. And I'll share with you the amendments that we've made over the last 4 months in relation to this. And then we have a sort of final clinical runway, which lasts about 16 months, where we prepare doctors for their new graduate practice as a doctor in Singapore. So this is basically where we are now. And if I can sort of orientate you, the red bar is sort of today's date and currently where we are with respect to the 4 years. I'm pleased to say that the final year down here have just graduated and will be starting work next Monday. Their work entry has been brought forward, but we've had pretty much our primary focus on getting this final cohort ready for graduation. As I explained, our first year, going to the top of the slide, they would normally be completing their preclinical and would normally enter their second year of clinical clerkships. But what we've done is we've brought forward their research and scholarship phase forward a full whole year. That's been helpful for both the clinical service and for reducing clinical demands on the service. We've also done something similar for the current second years, where we've at pretty short notice interjected their research and scholarship phase. What this has allowed us to do is to concentrate on our clinical training of our rising final years, so that they are the priority. Our biggest concern was that the rising final years were probably that group that were going to be most significantly impacted. The final years had all but finished their clinical placements. This third year, they really do need to complete their clinical final year in good order, so we prioritised. The movement of the scholarship phases has actually allowed us to reduce the demands on the clinical service, which will also coincide with hopefully the peak of the COVID pandemic. So again, we were considering both the clinical service demands as well as the educational service demands. We've had a whole host, and I'm sure many of you will be familiar with these things, you know, the requirements to wear masks, point-to-point travel's been denied, we've staggered arrival times. When we were looking at exams, we've also had to follow some of the restrictions in terms of clinical campus isolation that the ministry's also brought in, and a whole raft of other things around social distancing, contact tracing apps, and personal hygiene, many of which I'm sure you'll all be very familiar with. So any teaching activities, so we took a slightly different approach. From the 7th of February, things were suspended for about a month. But from middle of April, we've returned students to clinical training, and that's been only allowed by very strict and rigorous clinical training. We have also conducted in that time our final year examinations. And for those of you who want to find out a little bit more in detail, Kathy Borsico has published a paper in MedEd Publish on the significant adaptations we made to that. And I'll just show you some pictures, both of the clinical training that we've reinstituted and also the practical high stakes OSCEs exams, which we have conducted in context. So obviously PPE has been an important part of re-establishing clinical training. All students have to be trained and certified competent in PPE. We've also been allowed to continue other face-to-face essential clinical training, such as advanced cardiac life support and other deemed important clinical training aspects. We have gone, as our colleague has already previously discussed, gone to using telemedicine, and these are students actually in an exam setting taking a clinical history. And as you'll see, the views that you're seeing are the views that the examiners were provided for who were not in the room at the time of the exam. Obviously social distancing and all the other norms, but again, we made particular arrangements. We felt that the physical examination particularly was something that it was actually all but impossible to do remotely. And unlike other institutions in my own home country of the UK, where graduates were given degrees without any final exams at all and their clinical training was suspended, certainly a lot of the training was suspended in totality. So students would be doing, filling body bags and other sort of quite dramatic things, but not actually pursuing or moving forward their clinical training. We've also used the opportunity of hybrid simulation, simulated patients, and the technology to leverage in terms of assessment. So again, high stakes assessments were conducted because we were required by the Ministry of Health to ensure our graduates were properly assessed, that the assessment systems had full validity and authenticity, and that were conducted within the control measures I've shared with you already. So again, the examiners were not present, but they were able to view the conduct of the exam from multiple perspectives, and the team worked very hard in short measure to make sure that the views were more than adequate for the purposes of assessment and validation of their practical competence. So in terms of the assessments, the key principles that we've surfaced would be to obviously minimize in-person student to examiner interactions, minimize the number of simulated patients on site, minimize faculty and staff. And critical to the success of these endeavours has been that, the importance of testing and leveraging those technological solutions, both before you deploy them and whilst you are deploying them. Familiarise all participants, and so we were able to both familiarise the examiners and the students with the new arrangements in the weeks before the deployment. This is an issue that we've really focused on significantly. Student isolation does require that we provide additional and enhanced levels of pastoral support, care and well-being. We've had a wide range of events, including students and faculty coming together and sharing more light-hearted moments where they all brought their pets so that everyone could see and participate in something a little bit more light-hearted. But we also touch base with every class every week and have more regular faculty, staff and student wellbeing events just to check in on everybody. We've also developed through our pastoral care and student affairs team a lot of counselling and direct one-to-one support for, and we also are very vigilant in terms of, in sessions it's often clear that some students are a little bit less either participatory or demonstrating some signs of concern, and so we would actually actively follow up on those after the event to make sure that they were okay. And then finally, just some sort of celebrations. Last Friday we conducted our Hippocratic Oath ceremony. We cancelled our graduation ceremony until happier times, but we were able to conduct the Hippocratic Oath. We felt it was an important part of their transition into the workplace. We felt it was important for their personal transition as they join the medical workforce in a couple of weeks' time. And so we went through the process of giving them all backdrops. They practiced, they rehearsed, And it was a great sense of community, brought everybody together. It was fun and lighthearted, and the students actually did also make some comments as they concluded. So it was a good point of bonding for the school as we went forward. And there was the citing of the oath, which they could all read off the chat box, which I'm sure you're all busy reading at the moment. So I think really just to conclude, we've had some sort of different privileges and advantages. We've got fantastic infrastructure here. We've got fantastic bandwidth. We've got a very well-resourced school, but we have suffered from just that simple, basic loss of contact in terms of human-to-human interaction. We're particularly concerned about the impact in the medium to longer term of the loss of experiential learning and the practical sides of that. And so we're really working hard on how that might get addressed. And along the way, we've also looked at student anxiety. Nearly a third of our students reported, before they went back to clinical training, nearly a third of our students reported anxiety at the prospect, both in terms of their own fear, but also the fear of bringing the virus home to their parents and family. So we've also worked with them on that. Once they go back, the challenges seem to shift. The reality of the fear is a lot less. They understand that it's safe, but then they think about more sort of practical issues like broadband, Wi-Fi, and those sort of connectivity challenges and issues. One final point is obviously in terms of all of this e-learning is when you're sort of interacting with patients, there is a significant challenge around maintaining data protection and security of that data. So we've also been using the hospital-based Zoom system, which has enhanced levels of personal and data protection. So really similar but different challenges to, I'm sure, many of you around the world. As I say, we've also had some papers, one's just accepted in medical education on the student wellbeing, which will be out in due course. Kathy Borsko and colleagues have also published on the conduct of high stakes assessments in the last couple of months. Just for your information, we can circulate those references if required. And that's me from Singapore.
Thank you, Prof. Ian. Again, excellent presentation with a lot of solutions, and again, exact in time. So we now move to Yogyakarta. Prof. Gandes Retnuahu, Professor in Medical Education, Vice Dean for Academic and Student Affairs at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta. Prof. Gandes, the floor is yours.
Yeah. Thank you very much, Dean Ari, as well as Professor Albert, for the time, and also invite me to share and learn together from others. So I'm going to share 2 things that we learned and we do during the pandemic. This is about the academic affairs for our students as well as for student affairs. So I'm going to start with the academic affair first. As well as in the other places, we moved into the online platform. So this is how we adapt the lecture, the small group discussion or tutorial, the practical session, as well as the skill training during the pandemic. So in our case, actually, everything started at the middle of March. Before the middle of March, everything is still normal. So start from the middle of March, we moved the lecture into synchronous lecture, recorded lecture, as well as required reading. For the tutorial or small group discussion, we didn't use 7 jumps anymore, but through online learning, but we use a triple jumps approach where it starts with the synchronous online discussion, independent learning, as well as the third step, asynchronous discussion. For the practical session, it's also challenges as we already everywhere. So we provide several video, then the video learning followed by assignment or quiz to assess the comprehension, as well as discussion with the facilitator. The skill training is also challenges. So We also provide some procedural skills video they can learn, and then they can practice at home, and perhaps videotape and then submit the recorded practice to our platform. We call it as Gajah Mada Medical Education, medical e-learning. Last month, we already done evaluation. This is through survey to the student, as well as the study program conducted virtual meet and greet the students. So every batch, they are invited to raise their concern, to give us feedback, and also to raise some solution that perhaps more suitable for them. So based on the evaluation survey, as well as for the virtual meet and greet meeting, we understand that there are some strength and some weaknesses area for improvement for the online learning. So for example, for the strength, the student feel that it's flexible, more relaxed, no preparation to go to the campus. Some of them feel more confident to raise the question. Documented material can be learned later, but there are also many areas for improvement. So for example, too much assignment, reduce concentration quite easily. They expect more feedback, more interactive session, and also some of them raise the internet costs as well as the schedule change. So from the first 4 years, we think that we have to do more structured learning within one module. So for example, currently every single teacher only think about their own topic, and then they deliver, for example, everything in synchronous. The other student also synchronous, and then one teacher gives assignment, the other teacher also gives assignment at the same day. So it becoming too much burden for the student. So what we're going to do is one module team, one block team should work together, and then to rearrange again which one that's will be done synchronously, which one that will be done asynchronously, which one with the assignment, which one not necessary to be given assignment, and so on. So the student will be learning better. And for the field learning, we have a program, what we call as community and family healthcare interprofessional education. Allow me to present briefly about this program. So this program is followed by students from medical, nursing, and nutrition together, mandatory for first year until 4th year. They have a partner family to work with. They have supervision from our faculty as well as supervisor from health center. Because of the pandemic, everything switched into online learning for the first year because they haven't had a family partner that they know. So we asked the first year student to develop a campaign about COVID. It can be in the form of poster, podcast, educational video, online essay, whatever, and they have to promote it to their social media. This is the example of the work of the educational poster from first year student. This is the example of the essay and podcast from the first year student. And then this is, if you click it, you can see the example of the video that first year student make for the assignment. But for the second year and third year, because they already work together with the family partner, they have a family partner. So every group consists of 5 under 6 person. They have 3 partner family. So we use the partner family to work with. So every group with their partner family and supervisor as a faculty supervisor as well as field instructor working together. They make a WhatsApp group discussion, and then we make like a schedule what have to be done by the group of the student from day 1 until day 7. So for example, day 1, there are 5 topics that they have to educate to their partner family about COVID-19, cough etiquette, hand washing, social distance, how to increase immune. Day 2 is the material of day 1 plus seeking help to hospital. Day 3 is the material of day 1 plus environment hygiene. Day 4 is the material of the previous day plus tip to prevent stress. Day 5 is repetition of day 2. Day 6 is repetition of day 3. And day 7 is same with day 4. All the material provided by the faculty in the form of poster on video and uploaded in the website, Health Promoting University website. So this is how the interaction between the family partner, the student from 3 different background, medical nursing and dietitian, as well as the supervisor from the faculty, as well as from the field. So after a month of the program, we can target 420 partner family. So it's around 85% of our targeted family. There are evaluation, but I just want sharing evaluation from the student, from the supervisor, as well as for the family partner that we think is important. So here, how the student perceive about the online program, whether it's beneficial for student, they feel that they can take a role in a pandemic situation, and they also feel that the online education can enhance partner family knowledge regarding COVID-19, and online education also encourage partner family to do hand washing. So not only knowledge, but also doing hand washing, cough etiquette, and keep distance also increase endurance. That's the perception of the student, and this is the perception of supervisor and field instructor that I think quite in line with this perception of the student. And this is the perception from the partner family that also in a more in positive direction about this program. Of course, there are many challenges, and we try as hard as possible the solution. There are some family that do not have mobile phone or WhatsApp, so we extend to other family. There are very few family that refuse to contribute, so we recruit another partner family. Also, there are partner families that are so busy, so we should give more time and supervision. That for the field learning. And I'm going to move on to the clinical learning clubs that very challenges. So basically from middle of March until now, there are a mix between online and offline. So some departments still possible for the student to go to the hospital and safe zone and doing bedside teaching or taking a patient case and then followed by online discussion. But some of the department until end of May, for example, it's not possible to go to the hospital. So we adapted to the online platform, although it's not perfect. Yeah, and there are regular meeting on Friday to coordinate and to try to see the weaknesses, how to improve in every department. This is the example of the online case discussion, skill demonstration, where the teacher can demonstrate and then student from their own places can follow the demonstration to online platform, mostly using Zoom. Then there are also our teacher and our forensic department that develop interactive case management using application to facilitate students to learn about case management. And this is also some of the teacher that try to do modification on Mini-CX. So the teachers read the cases and the student in his own house can practice it to his family, and then student demonstrate through Zoom, so the supervisor can giving feedback. And then anesthesia and therapy, for example, this is how the procedural skill drilling is done. Until end of May, we try to evaluate the deficiency, what we have to do to fill the deficiency. So basically, until now, we have 4 groups of the students. First group consists of 37 students. They will end the rotation this month. So actually, the student is the group that less affected. They are going to prepare for national examination. So we're going to insert the deficiency through the preparation program for the national examination. The second group consists of 97 students. Their rotation will end at around December or early January 2021. They are more effective students. So the study program currently working together with clinical rotation team to design what we call as integrative rotation. So the integrative rotation will be over before national examination in February. So the student can follow the integrative rotation for very few weeks, and then to fulfill the gap, the deficiency they suffer because of the pandemic. Group T is 93 students. They start to rotate April 2 months ago. So what we do with this group is very close coordination and monitoring their progress, their weaknesses, and what we can do to make it help they can get a more chance to see the patient. Some of the department already asked to send the student outside our city or within our city, but different hospitals. So currently we are in the process of coordinating this one to increase the encounter experience to the student. Group 4, currently actually the student in their own host spread in our country consists of 140 students. They will start the rotation of July. So what we are currently doing is to provide protocol for mobilization to Yogyakarta, including self-isolation and so on, coordinate with the university for mobilization. For this group as well, close coordination and monitoring while observing the progression of COVID-19 is also done. That's regarding the academic affair. I'm going to move to student affairs. So in the very first week of the pandemic, I mean around 3rd week of March, we did survey to the student. From the survey, we learned that there are some concerns raised by the student. First concern is about the internet cost. And then the second is logistic, especially for the student who still stay in boarding house around the university. The third issue that the student raised about the psychological problem. So based on that survey, we try to help the students. So for example, for the internet cost, we have a student what we call as bidik misi and afirmasi. This is the student with a parent with low income. So all of them have we give assistant aid for having internet costs. But for the student that's not bidik misi or afirmasi, they can propose if they feel they need it, and then we try to verification. If this is verified, then we give also assistance for them. And so far, we already also provide logistic aid for the student who need, especially for the student who still stay in boarding house. We provide logistic, some food, some simple food for them. And this is the picture where we try to distribute the food, and the student organization also help us to arrange that one to identify who need it. The other one that also raised by Professor Ian Curran is about a psychological state of the student because of the COVID. So we have two psychologists that provide services and consultation. And during the pandemic, they moved from face-to-face counseling to telepsychology. So the student can ask consultation through email, WhatsApp, texting, or if necessary to do a virtual meeting like that for psychological consultation. The psychologists, the two psychologists that we have also provide practical tips for the student that uploaded in our social media. So for example, these are some of the topics that the psychologists write and share to the student through our social media. So for example, how to study from home, how to manage anxiety during COVID-19, how to deal with cabin fever, and so on. Student extracurricular activity also moved to online platforms. So there are some example of the student extracurricular activity that's still done during the pandemic, including clinical updates and then workshop about healing, essay competition, various online discussions. So everything that can be done to follow COVID prevention protocol is still done by the student. Something that's we proud with our student is that their initiative. This is the student-owned initiative that they join volunteer work. 100 of them join volunteer work either at their kampong, their village, and then at a province or district, as well at a national level. When we try to identify what kind of volunteer work that our students follow, we can identify there are several kinds of volunteer work that the student done, including education for the suspect of COVID, and then contact tracing, fundraising for buying personal protective equipment and donate to the medical staff, resident, and our hospital. And then they also join to monitor self-isolation, doing campaign, and then becoming volunteer in their village to protect unnecessary mobilization, working with the youngers in the village, also to campaign about the COVID-19 in his or her own village. Also distributing masks and food for vulnerable group of people. So for example, for people who still need to work because if they stop to work, they can afford for food for their family. So the student try to organize it and then distributing masks and food for them. It's very interesting as well because some of the students also decided to do voluntary work in our laboratory, helping for working in a microbiology laboratory and other laboratory that still are going on for helping to combat with COVID-19. So it's really their own initiative, and it's we really appreciate those things. There are take-home message that I want to share here. The first is that for the first 4 years, we need to have more structure arrangement within one block, harmonize the content within one block. So the teacher should not only thinking about their own schedule, but the coordinator should coordinate much better. So the student can absorb, can learn better from the better arrangement. The other one for the clinical context for clerkship, currently the study program works so hard to make a directory of learning resources so it can help the student to focus on what kind of topic, what kind of skill, what kind of disease they want to learn from, and it will be put in one directory to help the student. And for the field practical session, we're going to focus to help the people, the community surround us, how to face the new normal and what new normals mean. I think that's all from our institution, and thank you. And we learn a lot from other speakers. Thank you very much, Prof. Albert.
Thank you, Prof. Candice. Many nice examples, and also many nice examples what students learn different in this pandemic, and that they can use their creativity to do other things and good for the community. There are a number of questions. Most of them are really answered by the panelists, but still there is an important question: how do the different panelists see the new normal? Of course, it's very difficult to predict how things are going, but maybe Prof. Candice, you will want to give a short answer about the new normal.
First of all, actually at a university level, we have three scenarios, what we call as optimist scenario, moderate scenario, and pessimist scenario. The pessimist scenario that the online learning from the first until 4th year will last until end of this year. But for the moderate one, for the moderate scenario, it will be started at middle of August or September. So for that, we need to think very hard which one that actually the student need to go to the university. Even for practical session, we have to identify, and then what can be delivered into through online learning, and it's more effective, which one that's more effective and efficient. So we have to be brave enough to change to that direction. And then for the clinical learning, I think this is also a time for us to challenge ourselves. How can we make it more efficient? Because clinical learning always consists of knowledge, skill, attitude as well, which one that cannot be negotiated. Students should go to the patient, but which one that can be adapted and more efficiently done without doing to the patient. I think that's the challenge in education for the new normals. Thank you.
Prof. Ian Kern.
Prof. Albert. Okay, so I mean, I think medical professionals learn by doing. We've got our biggest challenge going forwards is, as Prof. Candice has just said, how do we substitute, or I don't think we can. So I think we have to adjust to the new reality. And I think I would also strongly advocate that we also need to understand how we make our assessments valid and meaningful in this new world as well. And I can understand why institutions have said it's just a little bit too complicated to run AAHCI-SEAs, but we've shown that you can do it, and you can do it safely. We've had no contamination of students, patients, or faculty by strict discipline around student cohorting, faculty cohorting, campus cohorting, strict hygiene measures, all of the other basic things. And if you do those things, you can keep both students and faculty safe, patients safe, but you can also, more importantly, retain the validity and the authenticity of the examinations such that you can graduate doctors that you know are safe. That, after all, our duty of care is to our public, to the patients that the graduates serve, and we have to retain that in amongst all of this morass that we're going through. So again, for me, it's don't waste a good crisis. There's lots of opportunities here for us to maybe get rid of a few things that people have always held on to for perhaps longer than they should. So let's use it to innovate. Let's use it to be creative. And certainly we found that you have to be, I showed you our curriculum. That's probably about version 40 in the last 4 months. So I think adaptivity, flexibility, I think it's also good discipline, because I think it's forced us all to really take a long, hard look at what's really important here. You know, what learning are we trying to create? And really, honestly, how effective, productive, efficient have our previous methods been? And I would challenge us all to think we could probably all do all of our medical education a lot better. You know, the information sharing is easy with various forms of e-learning. We had a fantastic seminar over the weekend on radiology. Actually, I think it was better than a lecture-based. You know, you could show detailed images close up. Everyone got a front row seat. They used poll everywhere. You could drop a pin. So you got, I mean, we had 600 students from the whole of Singapore doing this radiology seminar. It was fantastic. And you could see where they were all placing their pins as to what they thought the, so it was very interactive, very participatory. It wasn't just rehashing, filming a video or various other sort of also ran activities in e-learning. It was proper, new formatted, pedagogically robust educational activities. So I think don't waste a good crisis, really take stock of what is it we do need to do. And I would argue we need to examine them properly. We need to give them good clinical experience. But if we think that, we can then set about prioritizing those things and doing it safely and discharging our duty of care to all.
Thank you. Dr. Corali, your view on the new normal?
You're muted, Dr. Corali.
Okay, I agree with what both speakers have said. New normal. Actually, we don't know what it will look like. Okay, for us, our CHED has told us that we cannot go back to face-to-face classroom until September. So our school year will now start in September. For the meantime, what we're doing is, while trying to finish off the requirements of the previous school year, we have a deadline. If you want your grades, then you should submit by the end of the month. If you're willing to have a deferred grade, our university has allowed students to get deferred grades so that they can complete their requirements at a much later time. Okay, so that, but for the new normal, it's very difficult, I agree with both speakers, to really imagine what it will be like without contact with patients. I think there's still there's a need. You need to learn from patients. It's easy for radiology because that's such a visual thing. Maybe dermatology even, that's also kind of visual. And so there's a lot of teledermatology, teleconsults. So the new normal will include how to do teleconsults. I think that's going to be there. And then for physical examination, you can actually demonstrate it. You said via Zoom, yes. And then the students can do it at home and you can ask them to video, but do it at home on somebody with them at home. So a relative for physical examination. If you have this, I don't know if you have the stethoscopes. Instead of having a stethoscope, you have a stethoscope. So you can give that, it's like the edge of the bell of the stethoscope. You give it to the patient and he puts it over his chest, and then you can hear it by wireless what the heart sounds or breath sounds might be. So that might also be new normal. Well, hopefully when we have vaccines for COVID, hopefully we can go back to a better semblance of normal, but again, learn from what we've been doing.
Okay, thank you very much. I think we are now used all our time. I think I want to thank all the panelists to share their experiences and their learning. And although our situations are different, we really learned how dependent we are from internet facilities and possibilities. And that's different in the regions of the world. On the other hand, I think I saw a lot of creativity, and that's, I think, a good side of it, in a way that we can change things that would never happen if there was no pandemic. So I think there are also a lot of opportunities. So thank you very much. Thank you, Prof. Ari, being our chairperson and guest. And thank you, Habiba, for making this all technical possible. Thank you very much, all of you.
Thank you, everyone. And before
Thank
we
you,
leave,
everyone.
Thank you,
Thank
Prof.
you.
Albert.
Stay
Thank
safe.
you,
Thank
Prof.
you.
Ian, Prof. Landes, and Caroline.
Thank you, Prof. Ari. Thank you, Prof. Albert.
Thank you.
Thank you.
Bye-bye.
There's
Thank
so many
you.
questions from the participants.
So maybe can you send us the questions are here. Will that be sent to us? Maybe we can answer some of them that we didn't
yes,
tackle
absolutely.
in the
Yes.
Q&A.
And any
Okay, thank you.
additional questions, we'll email it to you, and we can share it as well on
Okay.
our website with the recording.
Yeah.
Right.
Okay,
Yeah.
thanks very much.
Thank
Thank
you.
you, Abiba.
Thank you.
You're welcome. Bye-bye.
Bye-bye.
You have a screenshot?
Sure. All right. 1, 2, 3.
Okay.
Yeah.
Yep.
Thank you.
Thank you.
Okay, thank
Bye-bye.
you.
Bye-bye.
Thank you, Abiba.
Thank you.
You're welcome. Bye-bye.
Thanks all.